Good morning to you all. Today I'm going to take a lecture on nutritional importance of the nutrition in the surgical patients. So the introduction of the importance of the nutrition in surgical patient are it is the while most of the patient will progress to an oral nutrition after the surgery, few who were preoperatively malnourished and those who have undergone major surgery often requires a nutritional support for wound healing and hypermetabolism associated with surgical recovery. So the nutrition is not only important in a surgical patient, it is also important in all the even a healthy individual to run a proper life. So when it comes to a surgical patient or any ill patients, nutrition plays a vital role in recovery of the patient from the illness. So the aim of the nutrition is perspective to the surgical patient are to identify those patients who are the risk of malnutrition and to ensure that their nutritional requirements are met by the most appropriate route in a way that minimizes the complication. Here, there are different types of nutrition like we can employ over the patient, but it is in our hands to ensure what kind of or what route of administration of the nutrition is mandated for each and every category of patient. For example, healthy, moderate malnourished patient can be benefited with the oral supplementations like a oral vitamin, multivitamins, or any specific supportive medications. But whereas in the bedridden patient and who has a high morbidity rate and who has undergone a very um, prolonged surgical procedure, so that kind of patient, or in the patient who have massive resection of the bowel, so those kind of patient will require a different type of nutrition support post-operatively and throughout their life. So coming first, physiology during the starvation at the time of the surgery. So during a short fast that is for the 12 hours, the plasma insulin level falls and the glucagon level rises, which facilitates the conversion of the liver glycogen into the glucose. Though stores of glycogen are present in the muscle, it can be utilized directly as it needs to undergo glycogenolysis and then converted to the glucose via Cori cycle. But when the fasting exceeds beyond the 24 hours, the de novo glucose production from a non-carbohydrate precursor takes place. That is usually from the amino acids. And while exceeding 24 hours, in order to meet the energy requirement, the body itself makes the fat oxidation takes place, where the glycerol and the fatty acid plays a major role as a tissue fuel. The hepatic production of the ketones from the fatty acid starts usually only after the 42 to 72 hours of the fasting, during which the ketone body becomes a primary fuel for the brain. So usually the primary fuel for the brain in the healthy or a normal individual is glucose. And when it exceeds beyond the 72 hours of the fasting, the glucose gets exhausted. Therefore, in order to fuel the brain, though, the ketone bodies becomes the primary fuel. So how do you assess the nutrition in a patient? So the nutritional assessment can be done by a body weight and the anthropometry. This is a simple method to assess the nutrition status, which is to estimate the weight loss. Measure the body weight is compared with the ideal body weight obtained from the tablets or fluids. That usually the definition of the weight loss is unintentional weight loss of more than 10% in preceding 6 months is a bad prognostic indicator. So so for the significant weight loss definition, what we say is unintentional weight loss for about a 10% of the body weight over a period of 6 months is called as significant weight loss. And it is also named as a bad prognostic indicator. The frequent BMI assessment helps to rule out the nutrition status of the patient. So the BMI is calculated by weight in kilograms by the height in meters square. So the body mass index by the with the calculation of the body mass index, we can categorize the patient into underweight, normal, overweight, medically obese. In an obese, we have three different categories: one, two, and three, and the third one is called as extreme obesity. So the underweight usually we mention as the BMI which is less than 18.5, and the normal acceptable body mass index is 18.5 to 25, and the overweight category are from 25 to 30. And when the patient is going to be labeled as the medically obese under category 1, they usually have a BMI of 30 to 34. And the category 2 of a medically obese patient is from 35 to 40. And the extreme obesity will be labeled of BMI who has a more than 40. So the anthropometric technique, which measures the skin fold thickness and the mid-arm circumference, permits estimation of the body fat and muscles mass, which indirectly depicts the measure of the energy and the protein store of a person. So the bioelectrical impedance analysis. It is another technique where the intra and extracellular fluid volumes are estimated, but these measurements are impaired by the presence of edema. So the bioelectrical impedance analysis is one of the two which can assess the intra and the extracellular fluid volumes. But there are numerous conditions where the reading goes, we'll get an error in the reading. The one more thing we use is the MUST tool. That is nothing but the malnutrition universal screening tool, which is a 5-step screening tool to identify the adults who are malnourished at the risk of undernutrition. So the MUST tool consists of the BMI, weight loss in the 3 to 6 months period, acute disease effect, and it with this we like conclude into an overall risk of undernutrition, and we categorize into 0, 1, 2, or more than that. So the BMI who has a the person who has a BMI of more than 20 is usually given a 0 grade, and the grade 1 goes to for 18.5 for the person who are in the 18.5 till the 20, and the score of 2 is given for less than 18.5 BMI, and the weight loss in 3 to 6 months of period. So less than 5% is given as 0, 5 to 10% is given as grade 1, and more than 10% given as score of 2. And the acute disease effect adds a score of 2 if there has been or is likely to get or no or very little nutrition intake for more than 5 days. So these scores are added upon together, and it is assessed as when the score is 0, the overall risk of undernutrition is very low, and if the score is 1, it is on medium, and 2 or more or high, it is considered as a threatening situation. So the score of 1 is usually the patient who comes in a score of 1, usually the observation is mandated for those patients. And for a score of 0, we give a routine clinical care. So the nutrition requirements for a patient. When planning for a feeding regime, patient should be weighed, assessed, and assessment should be made of daily energy and protein requirements. So the basic and the fundamental things which has to be monitoring regimes are the categories which comes when monitoring for in perspective of daily, the routine days are the body weight, fluid balance, full blood count, urea and electrolytes, blood glucose level, electrolyte content and volume of the urine output, and intestinal losses, and the temperature. So these factors should be determined each and every day. And the weekly thing which has to be monitored are urine and the plasma osmolality, calcium, magnesium, zinc and phosphate, plasma protein including the albumin, liver function tests including the clotting factors, thiamine, acid-base status of the patient, triglycerides. And the fortnightly which has to be monitored are serum vitamin B12, folate, iron, lactate, and the trace elements like zinc, copper, and manganese. So these are the factors which has to be done on the respective days or the weekly wise or the fortnightly, which with which we can benefit a lot in assessing the nutritional requirements of each and every bedridden patient in the hospital. So normal energy requirement of each and every individual are nearly 2000 kilocalorie per day. And the hospitalized patient, usually the required energy requirement for each and every day is 1300 to 1800 kilocalorie per day. And comes the carbohydrate requirement, which is usually 2 gram per kg per day of carbohydrate is required to meet the needs of the CNS and the certain hematopoietic cells. The non-oxidized glucose are primarily converted to fat. And the fat requirements for a patient or for a normal individual on every day, the dietary fat is composed of triglycerides and predominantly 4 long-chain fatty acids. Energy during the parenteral nutrition should be given as a mixture of fat together with the glucose. There's no particular ratio of glucose to fat is optimum as long as under all the conditions the basal requirements for glucose is like 100 to 200 gram per day and essential fatty acid is 100 to 200 gram per week are met. This dual energy reduces the metabolic complications and enhances the substrate utilization. So coming to the protein part, the required daily amount of protein in a normal individual is 0.8 gram per kg per day, and approximately it consists of 56 grams per day for a man. Then the vitamins, minerals, and the trace elements. This is considered to be the essential component of the nutritional regime. The water-soluble vitamins like B and C plays a vital role in collagen formation and the wound healing process. Example, in the postoperative period, the vitamin C requirement increases 60 to 80 milligram per kg. Likewise, the B12 supplementation is mandatory for patients who have undergone intestinal resection, which is going to be a massive intestinal resection and alcoholic dependence cases. In case of diarrheal disease, patient daily monitoring of serum electrolytes is advised, as the patient is more prone for serum electrolyte abnormalities. So, when coming to a surgical patient, the effect of the bowel resections has a different disadvantages. For example, minimal bowel resection carries of very less morbidity postoperatively, while the massive resection or a significant resection of the bowel can cause a significant side effects postoperatively and also during his lifetime. So the effects of the resection is very important in terms of surgical patient. So the nutrition support in the bowel resected patient is to be monitored very closely. So the jejunal resection results in no significant alteration of fluid and electrolytes as the ileum and colon can adapt to absorb it. Whereas when the ileum resection is done, a part results in a significant enhancement of gastric motility and acceleration of intestinal transit. So the regular parenteral vitamin B12 patient is advised a fast restricted diet. So what do you mean by short bowel syndrome? Short bowel syndrome, it's a major thing to be considered in the surgical patient. The patient who have undergone a short bowel resection of excess of 200 centimeter usually needs jejunostomy. Initially, they are divided into two categories, net absorber and net secretors. So the net absorbers are usually have more than 100 centimeter of jejunum, hence they can be managed without supplementation of parenteral fluid as they absorb more water and acid from the diet. Whereas the net secretor have less than 100 centimeter of residual jejunum. Therefore, the patient needs the supplements. The usual daily jejunostomy output may exceed 4 liters per day. So in these kind of patients, consumption of hypertonic fluids are restricted to less than 1 liter per day. And the complications are peptic ulcer, cholelithiasis, which is due to interruption in the enterohepatic cycle of the bile salt, renal stones, which is due to the hyperoxaluria, and some may develop slurred speech and ataxia, which is due to fermentation of malabsorbed carbohydrates in the colon to the lactate and absorption of this metabolite. So treatment for these kind of patients are low carbohydrate diet and anti-secretory drugs. So drawbacks in these patients can be like a muscle wasting, the most of clinically clinical factor which can be seen in the patient on the daily basis, and the immune dysfunction, delayed wound healing, and the systemic involvement, which is quite rare. So the nutritional support for the patients. The indication for the nutritional support for the patients are who has sustained 5 days of inadequate intake or who is anticipated to have no or inadequate intake for this period should be considered for the nutritional support, whereas the rest of the patient will not require a significant amount of nutritional support in the post-operative. So the types of nutrition are enteral nutrition and the parenteral nutrition. The enteral nutrition refers to method of feeding that uses gastrointestinal tract to deliver part or all of a person's caloric requirement. Delivering by use of a feeding tube like a nasogastric tube, gastrostomy tube, and jejunostomy tube. So this is called the enteral nutrition. And a sip feeding. Supplementary sip feeds are used in patients who can drink but whose appetites are impaired or in whom adequate intake cannot be maintained. These feeds provide nearly 200 kilocalorie and 2 gram of nitrogen per 200 ml of calorie. The tube feeding techniques in these patients are conventionally 20 to 30 ml administered per hour initially, then gradually increasing to goal rates within 48 to 72 hours. Usually feeding is discontinued for 4 to 5 hours overnight to allow the gastric pH to return to the normal, which can reduce nosocomial infection, nosocomial pneumonia, and aspirations. So this is a picture of the gastrostomy tube inserted in the patient. The three methods for inserting a gastrostomy tube are percutaneous, which is through the skin, endoscopic gastrostomy tube, laparoscopic technique, and an open surgical procedure. And this is a nasogastric tube. And this is endoscopic gastrostomy tube procedure. Here we can see the endoscope visualizes the stomach, and then a tube is gas. And this diagram shows the position of a percutaneous jejunostomy feeding tube. So the uses of the enteral tube feeding used to feed patients who cannot attain an it is done in the patient who cannot attain an adequate oral intake from food or the nutrition supplements, or who cannot eat or drink safely. For example, like a coma or depressed sensorium or neck trauma or critical illness, etc. Coming to the complication part of the enteral tube feeding, the complications are few, which is like the tube malabsorption, malposition and displacement, tube blockage if buildup of solidified diet, installation of chymotrypsin may salvage a partially obstructed tube, and the tube leakage or a breakage, tube clogging, and aspiration. So coming to the parenteral nutrition, the feeding the patient intravenously with a nutrition formula that contains glucose, salts, amino acids, lipids, vitamins, and dietary minerals. It is by bypassing the process of the eating and the digestion, indicated when the energy and the protein needs are not met by enteral administration. Indication for the parenteral nutrition are non-functional GI tract, impaired absorption. Example, bowel obstruction, massive resection of the small bowel, short bowel syndrome, Crohn's disease, and ulcerative colitis. The route of administration of parenteral nutrition are through the through the peripheral route or the central venous route. Peripheral feeding is for the short term of 2 weeks, delivered through the peripheral vein. The most common complication encountered in the peripheral uh, cannula are thrombophlebitis. As the central venous route, uh, secured through the subclavian, internal or external jugular, which is commonly chosen, is done. It is this route are secured for a long-term parenteral support. Hickman's line are preferable, which is inserted under fluoroscopic or ultrasound guidance. This incorporates a small cuff which sits at the exit site in order to prevent dislodgement, which is confirmed by the chest X-ray. Most convenient being the infraclavicular subclavian approach, as the catheter lies flat on the chest wall. So here comes the all-in-one parenteral nutrition solution, which is frequently used in the surgical patient after the massive bowel resection, and those and for whom the patient has been for the patient who has been kept for in a infused nil per oral state for more than 48 hours. Usually, the total parenteral nutrition is stored between a 2 to 8 degrees Celsius, and once the parenteral nutrition is commonly administered through the central venous route, which is the most preferable route, or as a central peripheral uh, route can also be administered. This TPN should be administered within 24 hours of opening the seal, and it has its own flow rate, which is usually in adults, which is kept at the rate of 60 to 70 ml per hour. So this approximate volume, the approximate volume of the TPN is about 2,100 ml per bag. The solution contains electrolytes preloaded with multiple trace elements, iron, multivitamins, except the vitamin K. As I said before, like it is stored in a 2 to 8 degrees Celsius. It has expiry up to 90 days from the date of compounding, which is stored as a 24 hours at room temperature when it is started. The complication pertaining to the total parenteral nutrition are, which is related to the overfeeding, hyperglycemia, which is more common because of the insulin resistance in a critically ill patient. Even during modest rate of glucose administration, which is directly creates a high risk of infectious complications. Hepatic steatosis, hepatomegaly, hypercapnia, fluid retention, electrolyte abnormalities, and also can occur. Hypercholesterolemia and hypertriglyceridemia due to excessive infusion can occur, and hypercalcemia, hyperchloremia, metabolic acidosis due to excess amino acids infusions. Complication which is related to the line are, the IV route are the catheter-related sepsis on insertion, pneumothorax, air embolism, pleural effusion can also occur. The recommended food after the surgery are dairy products, fiber-rich fruits, citrus fruits, vegetables like carrots, sweet potatoes, spinach, and mushrooms. So these constitute the nutritional support in the surgical patient, which is in a shot, which has a more weightage in the postoperative care of the patient. The nutritional care not only improves the patient status, also helps the surgeon to make the patient recover from the wound, especially when wound debridement cases and so in a diabetic ulcer wound in the postoperative wound debridement. Each and every day, the patient should be assessed for the nutrition status and the oral supplementations or the IV supplementation, which has to be given at the right time to be given in order to have a good outcome of the wound, as well as not only in the wound patients, is also helpful in bowel resection, whatever the patient which has been given care in the post-operatively. And also medically, the nutrition support in the patient has an enormous benefits for the recovery of the patient from the illness. So this is all about the nutrition status of the patient and nutrition importance of the nutrition in a surgical patient. Thank you.